I would now invite Javaid Rashid, who is a PhD scholar at the Center for Social Medicine and Community Health, Jawaharlal Nehru University. Javaid, if you can keep it as quick and brief as possible.
I will ask the research study, which was titled HIV/AIDS in Health Services, Misaligned Policy and Maligned Subjects. It will continue with the debates and discussions that happened since morning, and through the case of HIV policy, it will try to contextualize these thematic discussions which happened since morning. As we know, HIV/AIDS has emerged as a contemporary transnational challenge, and which has been capable of bringing out the best and also the worst in people. The best when in solidarity people join together to combat government, community and individual denial and to offer support and care to people living with HIV/AIDS. And the worst when people living with HIV/AIDS are stigmatized, dehumanized and ostracized by the society. Underneath this simplistic understanding, there is a deeper political economy, rather politics to it. And one should know that conceptualizations of HIV/AIDS has roots in colonialism and racism. The policy paradigm which has tackled HIV/AIDS is predominantly shaped by biomedical paradigm and reductionist approach, which ignores critical analysis, power relations, inequities between socio-economic groups and nations, or other socio-economic determinants of health. Rather, it focuses on interpersonal dynamics, behavioral change models, individual lifestyles, and on already marginalized groups. The over-medicalization of HIV/AIDS policy, as I said, has been shaped by biomedical approach, which has an understanding that HIV virus infects a human body and subsequently the infected body develops AIDS. And the strategy of this policy is creating barrier between human body and HIV virus, or manage it if virus has already infected a body. And the perception is that people are ignorant, not aware and show irresponsibility. And the method is behavioral change, drug therapy is enough to tackle the pandemic. And the policy is creating categories and in fact furthering marginalization, creating targets out of certain at-risk groups and branding it as success. So this diagrammatic representation shows that HIV/AIDS is in fact beyond infection in body. But unfortunately, the policy paradigm or the policy has focused on just part of that is signified as B, that HIV in human body. It has neglected the pre-infection life and the post-infection life altogether. Though pre-infection life is shaped by the socio-economic determinants, and where B, the HIV in human body, is just a physical condition and which leads to socio-economic consequences. So is the policy then missing the wood for the trees? And when we talk of political economy related to HIV/AIDS, the global or national responses to HIV pandemic are linked to geo-economic dynamics and the political factors at diverse levels. How political decisions determine responses to HIV/AIDS, or how the epidemic becomes a factor in decision-making among political actors. Linking HIV/AIDS to development issues such as poverty, socio-economic inequality, and gender disparities, etc., is of little interest for donor or development agencies. Even as the focus is to widen the availability of ART, there is hardly any discussion on the availability of primary health care and integrating HIV care with it. International agencies like WHO, World Bank, IMF, etc., who fund and design major HIV/AIDS programs across the globe, have also played a crucial role in weakening public services through institutional reforms, especially in the third world, as we were discussing since morning. This study, this background, attempted to understand HIV/AIDS from a critical social science perspective, how HIV is linked to contextual and structural factors like poverty, inequality, and marginalization. What are the socio-economic consequences of the infection? Why a disjuncture exists between the policy and issues of people living with HIV/AIDS? The broader objective of the study was to explore the socio-economic implications of AIDS on the affected people, issues of stigma and discrimination at various levels of their interaction in the society. Method, the study was conducted, cases were selected considering the efficiency research to eliminate the ways people experience of and socially construct meanings of HIV/AIDS. This study adopted a social interpretative approach, analyzing it. While respondents' accounts are not seen as revealing any generic truth, rather they are treated as stories whose meanings are situationally located and require to be discovered. Recruitment in the study was on a voluntary basis with oral consent of the individual. Respondents were assured of anonymity and were encouraged to terminate the discussion if and when they deemed it appropriate to do so. The major findings, as I said, this paper is an outcome of the research study which has focused on lived experiences and self-account of people living with HIV/AIDS. This paper has been divided into themes that reflect the range of issues that people with HIV/AIDS are facing, and it also attempts to understand or identify the policy level insensitivity that diseases the health services in India. These are the thematic discussions that have shaped the paper. Like changes perceived by people living with HIV/AIDS after being declared as infected body, initial psychological crisis, suicidal tendencies, fear of anticipated death, fear of stigma and discrimination, and withdrawal from interpersonal and marital relations is what dominates when they are declared as infected body. That follows with self-discipline and restricted interactions with children and other family members. Exposure to such adversities enhances their personal agency and resilience, and they start derive positive meanings out of this suffering for the understanding of the infection, which is those relatives, networks, health NGOs, and collaborative activities among themselves in people living with HIV/AIDS. But economic adversities and livelihood insecurity generally complicates the scenario. And when disclosure of HIV positive status, like in this study, 18 out of 20 respondents had disclosed their positive status to their close relatives. Family is seen as a source of care and support, and participants tended to not to disclose their serious status to people outside their families, not even to health professionals outside HIV-specific institutions. Response of the family. Initial and immediate reaction of dejection from the family. And as the family understands the infection, subsequent acceptance and support comes from close members and relatives. In-laws are seen as the main source of stigma and discrimination. Felt stigma was dominant in the self-narratives of respondents, and enacted stigma, which is experienced, rarely comes into the narratives. As people living with HIV/AIDS disclose their sero status selectively, they live a double life with dual identity, which has implications for their health care or availing healthcare services. The fear of stigma in healthcare settings forces the HIV positive people to seek health care from that doctor or health personnel who is aware of their positive status, or most times to seek it at those health centers that are far off from them. Economic hardships like loss of productivity, livelihood, or income source, medical expenses adds to their suffering, as the expenses for control and treatment of opportunistic infections weighs over their family budgets, and economic adversities affect their family status, upbringing of children, or ability to take care of familiar responsibilities. So when we talk of the policy which is misaligned and that maligns the subjects, people living with HIV/AIDS, because the content of the policy has been overemphasizing the behavioral change therapy, which has increased surveillance. Like if you take the case of ICTC centers or counseling centers in hospitals, which are isolated and segregated, and which are kind of fragmented policy manifestation, which is just to regulate this infected body. And while mystification and medicalization of the body infection created a global scare with regard to HIV/AIDS, has further serious implications on the people living with HIV/AIDS or affected with HIV/AIDS, like their families, children, others. The way this biomedical understanding of HIV people has also been of concern, because use of science, message, and language, which is loaded with morality discourse, has far-reaching consequences for the people. And the meanings people derive out of such and perception they develop of infected body and infection within specific social cultural contexts. Particularly, the social construction of HIV in such scenario has fueled the marginalization and discrimination of people living with HIV/AIDS. These people get caught in vicious circle of stigma and exclusion that perpetuates inequality for them at every level of their social interaction. And the bottom line could be set as that vulnerability to HIV, getting infected with HIV, and managing HIV and AIDS is determined by the position of the individual in the socio-economic spectrum. Behavior is just a manifestation of that. So policy needs to recognize socio-economic inequality, and the focus has to be beyond behavioral change. Thank you.